welcome to our webinar series. Thank you to everybody that's been following us and attending the webinars over the last few weeks. We hope you are enjoying them, and if you are, please don't forget to leave us a comment, subscribe, and follow us on social media. You can find details on our website, and I also provide some details at the end of this webinar. We are AFB UK. For those of you who don't know us, AFB UK stands for Association for Black and Minority Ethnic Engineers, and we aim to create engagement and provide support and promote higher achievement in education and engineering to professionals and students. Today, we do have a fantastic event for you. Dr. Amle Inusa, who has been working across some of the London busiest A&E departments during this season of COVID-19, is joining us today to discuss the disparities with the BAME group in the coronavirus crisis on the NHS and the action steps that she believes are needed to effect positive change, not only in the NHS, but across different industries. This is an excellent session, especially considering the times that we've been living recently. Before we start, and because Dr. Amle was having some technical issues, I'm just going to go through a quick icebreaker. So I hope you can engage and entertain me by answering how you have actually been feeling this week on the chat box. And I'll just start by saying that this week has been a mixture of anxiety, but also feeling hopeful with the future. So if you can entertain me and just give me a few answers of how you have been feeling this week, and this is in general, you can be feeling great because it has been, well, not so sunny, but not raining as much or anything. Tiring, but learning a lot. Yes, I can relate. Angry, frustrated, stressed, unsurprised. Yeah. Definitely relate. Hi, Amle. Hi, everybody. This is Dr. Amle Inusa. I was just asking people to tell us how they're feeling this week. And I mentioned that I've been feeling a bit anxious, but also hopeful. And we've had a few of the answers on the chat. And I definitely can relate to all of them, really. Yeah.
Can I just say, first of all, that's so funny because Taylor literally never calls me Dr. Amle Inusa. We've lived together since January, and that's the first time. So, guys, I should be with you right now, but this is not our relationship. It says, my name's Amle, but I'm signed on under a Winnie, and that's my younger sister. She is a systems engineer. I could pretend I know what that means, but all I know is that she communicates between like someone who's commercial and someone who's technical, and that's like my limit in my understanding of what systems engineering is. So yeah, I'm not Awani, I'm Amle. Nice to meet you all.
Thank you, thank you. I was trying to be professional and be respectful of your profession. But okay, let's go with Amle. Yes. We've had another answer saying focusing more than previous weeks to push on actions. I like that, yeah, because I think we all need to learn, but also start acting and start doing things. So yeah, so Amle, I've kind of introduced you already, and you've introduced yourself. So I think we're ready for you to start. And again, thank you for joining us today.
No, not at all.
This very topical issue.
Absolutely. So I'm just going to open up Zoom on my phone so that if people have chat questions, I can at least read them on my phone at the same time. And I'm all for having this as an open discussion because I think this past, like, I was going to say week, in particular with like George Floyd and BLM has raised a lot of questions, but particularly over the past, well, I think we're nearly into our 3 months now. So nearly, I think we're 11, 12 weeks now. Yeah, that we've got so many questions, I'm sure. So let me just try and open up my phone and then I will open up the presentation. Sorry guys, this is my third laptop I'm trying. So let me join without video here. Bear with me. Okay, I hope you can't hear an echo.
No, we can't.
Perfect.
Or at least I can't.
No, I think everyone looks pretty relaxed, so that's perfect. So I've opened up my chat screen there, and let me just see. So whilst we do that, I'll just introduce myself a little bit more. So yes, my name's Amelie. I'm a junior doctor. So I'm in my 4th year of work, which means I've gone through the 2 years of rotations where you do lots and lots of different jobs. And now for the past 2 years, I've pretty much been locuming. So that's like picking up jobs here and there in A&Es across London. So currently I work in a couple of different A&Es, and there's been obviously a lot of change over the past couple of months. But it's really opened up my mind and the rest of my colleagues' minds about what's really going on in terms of what that means, particularly with our most vulnerable populations, which is going to be interesting as I come to talk a little bit more about COVID, but also BLM and the plight of BAME people or BAME patients within the healthcare system. So also, when I was doing my medical degree, I took a year out to do a master's in ethics and law. So my interests really lie in ethics. And I think a lot of the times, whenever you're really looking at ethics and discussing stories, it's really important to understand like the legalities and what it means for populations. So yes, I have lots of random little interests here and there. And so they'll probably kind of tie in. But my last big interest is probably media and social media. So you will definitely see that in this presentation. And I thought I would do something slightly different where I take you through a journey of COVID, but also a journey of BLM as it pertains to the NHS with social media. So bear with me, guys. Okay, this is probably unlike any presentation you've seen before. And let's get this up.
You should be able to present now.
Yes. So let's try share screen. See, I can talk for England when I need to.
We like that, don't you worry.
Sorry, I'm just opening it. It's because I was doing it on a Mac, so I'm opening up in a PDF, unfortunately, but it should have the same thing. Can you see my screen?
Yes, we can.
Okay, so sorry, this is the way we're going to do it rather than on PowerPoint. But I thought I would change the topics ever so slightly. So my topic title is I Don't See Color. Why BAME? So BAME being Black and Black Asian minority ethnic is a lazy, dangerous, and centers whiteness. So let's go through this. So Shayla really asked me to talk about COVID and coronavirus, and this was a couple of months ago. So actually, when we think about what our understanding of coronavirus was in the general public, it was very limited, even though the information and the education we understand about it now hasn't really changed. So I think when we look back to what our government has done compared to other governments, I won't compare America because that's a law on itself, but when we look at like New Zealand, for example, actually the education was very different as it pertained to the public. And the other thing I also wanted to talk about was institutional racism in the NHS and how sharing data, but particularly data within context, was really helpful for my profession to understand. And I'm literally only talking about the past week. So let me keep going. Towards the end, I want to start talking about the things that every profession really in the UK can learn from the NHS in terms of like data gathering. Also some of the thoughts I've seen as I did a quick Google of engineering and the problems that engineering has in terms of institutional racism. And when I say institutional racism, I'm not talking about like the hate of one group. I'm really talking about the different structural inequalities from birth, childhood to certain attainment, the way people treat you or the way people perceive you to be, and how that really affects us in our professions later on. And for us in particular as doctors, when we're thinking about the people we affect, we also affect those who are more vulnerable to us, which is always a case of patients. So particularly when I'm thinking about authority figures, I think it's really important for employers, number one, but also doctors, police, and people who have people under their authority to really consider how their racial lens affects the way that they then interact with certain people. And that goes for us, whether we're Black or brown or white, because we will all have these implicit biases that we have kind of taken in ourselves. So this presentation is everywhere, but that is the way my mind goes. So here we go. So I said stories are important. Also, data is important, but context is everything. And I think that's always important to come back to. And let's go through. So back to stories are important. And I thought I would share something that I shared on my social media last week, and then we'll take it from there. So you won't be able to see this text, and nor can I, but I remember writing it vividly. So the Amy Cooper story came out, I think just over a week ago, maybe even nearly 2 weeks ago. And Amy Cooper, if you guys can remember, she was the woman who was in the park with her dog, in New York. What's the park called in New York? Central Park, there we go. So she was in Central Park with her dog, and she was asked to, yes, Central Park, Karen, someone wrote, okay. And a Black man who was also bird watching at the time asked her to put her dog on a leash because that's just park rules, and it's, I don't know much about birds, but apparently it helps the amount of birds that you have in a certain area. Anyway, so she'd asked him to stop, and what that video kind of showed was the way that she was able to like weaponize her tears and weaponize her position in society, by essentially calling up the police and telling them that there was a Black man, he was attacking her, and she changed the way like her voice and the intonation of her voice sounded, and that came to her, and that came, then he recorded it, and then that's when it blew up in the media. Then I think just that same day, that was a day that we all heard about George Floyd and saw that tragic video of the policeman kneeling on his neck. So I thought I would share the story of who my Karen was, because that's how people referred to her initially, because they didn't know her name. And I thought I would share that on my Instagram page. And as soon as I shared my story, which I won't go into right now unless we have time right at the end, I started hearing lots of different voices, lots of people who'd have had experiences in the same way. On the other hand, of someone else who had microaggressions against them, but also like quite inherent views about what Blackness really means, and use that to weaponize their voice against other people. So I shared that. So let's go on to data is important. So data is obviously important, and we all know that. So I thought, let me go back to my Instagram and see times that where I've shared data when it pertains to institutional racism. So as you all know, lots of companies released their gender pay gap reports in 2019 and some years before that as well. And the NHS is one of the institutions who also reported on ethnicity, which they haven't quite carried over into their COVID reporting, but that's another story. So the NHS reported on their data as it pertains to the pay gap. And we all know that pay gap doesn't mean directly how much you're getting paid for one role, but it kind of reflects who's getting paid higher salaries, where these discrepancy lies, who has more opportunity to access certain jobs or have like certain, so with consultants in the NHS, they're also able to get monetary awards from their peers. So who's getting those monetary awards? So anyway, I looked through the data and I did a little calculation on my own. And what we could see was between men and women, let me just see if I can quickly look. So between white men and white women in the NHS, doctors I'm talking about only, was white women were making £1.19 and white men were making £1.38. So I thought, oh, interesting. That's quite a large discrepancy. We have like largely, I think it's like a 55% women and 45% men split amongst doctors. So I thought, okay, that's interesting. Let me look and see what happens to Black women. So I did my own calculations, and rather than the numbers being closer to white women as I thought they would be, actually the Black women was £1. So £1 for Black women, £1.19 for white women, and £1.38 for white men. And of course that brought lots of conversation, and you can't always show data without context. So that's why I wanted us to think about what data looks like without context. And in that last slide there, which you can't see the words, but actually there's lots of questions people had about which group of doctors is this between? Do they have the same attainment? Are there the same numbers amongst consultants as there are between junior doctors? So there were lots and lots of questions that we spoke about. But I have my own personal thoughts on it, but which I might share with you towards the end. So finally, everything. So let me see if I've shared that here. No, I haven't shared it here. So what I'm going to do now is go back down to coronavirus. And if you guys want me to skip the coronavirus stuff and skip straight ahead to institutional racism in the NHS, just please message. I'm looking at your chat here. So please ask questions as I go along. I don't like to be talking to myself. So a couple of months ago, this was on the 16th of March, a couple of days prior to lockdown, I could see that there was so much furore and questions going around about coronavirus and what it is. On my Instagram page, I always do a sort of question, which it will say, help, I'm overloaded and confused about coronavirus. And then I will say, here is what I know to be true. So this is the post that I decided to create, and actually got a lot of interaction between people, and people were sharing with their friends. And it just kind of highlighted what people wanted to know at the time. So I'm taking a step back and talking about coronavirus. So I don't want to tell you guys stuff that you already know, because I'm sure you've known this over the past couple of months, but we all know that at the beginning we were thinking of, well, coronavirus to be a novel respiratory tract infection, similar to like an influenza virus, only that obviously it behaves very differently, but it affects the same populations who are typically affected by viruses and other conditions as such. So I did a little slide on what is coronavirus, how do you catch it? I'm sure we all know. It's particularly respiratory droplets. So it's not airborne. You can have respiratory droplets which will tend to suspend into gravity and then they will drop. Obviously, if you're on a lift or you're on the tube, for example, or what we call a vacuum, there's no air being allowed in. So on the tube, keep the windows open, which I'm sure most people are doing anyway, and make sure that you're only getting to lift by yourself. But this is the way that the respiratory droplets spread. And then you've also got environmental contact, which is also purported to be probably the most common way of spreading coronavirus. So washing your hands is very important. And actually washing your hands with soap and water is way better than washing your hands with just antibacterial gel. People also had questions at the time, could it be transmitted by fecal oral transmission? No, there's not been any cases, and that's the same also with if I'm in a swimming pool, can it be transported that way? And actually we've not seen any cases in that sense either, because it doesn't travel in like water droplets as such, just respiratory droplets. Okay, so then the next slide I did was how do we prevent the spread? And this was just very basic information, which was a good place to put it. Who is most at risk? So at the beginning, we thought, okay, just like other viruses, the higher risk populations will be those who have a lower, who have a more immunocompromised state. So we're talking older people, we're talking people with severe or chronic medical conditions, people with asthma were behaving differently, people with diabetes are more prone to have infection, and also heart disease. We know that's a systemic condition rather than a condition of literally just the heart. Immunocompromised because they're on certain medications, which are a lot of people actually. And then obviously the people who are also most at risk are those who are higher risk of exposure to COVID-19. So those are your caregivers, those are your healthcare and lab workers, those are your travelers, and so people who would like traveling, like on the aeroplane. And then of course, and now we see that the other people who have the higher exposure in London have been taxi drivers and transport workers. I think taxi drivers actually had the most deaths within the UK amongst that group. So I went on to why all the social distancing and isolation and lockdown, and I think this was information that when we look back, that our government didn't really explain and share with us at the time, but it was very important for the public to understand why we are doing certain things. So to tell people to stay at home, to wash their hands, people will internalize that information and almost perceive it for whatever they believe it to be. But if we don't actually give the context in which that information arrives, then it doesn't allow people to make their own sensible decisions. So whether it's you thinking it's better to meet up with one person and meet up one-on-one with like 10 different people versus meeting with just one household all the time, actually the transmission, if you were to understand why having social distancing was important, would allow you to make safer decisions. But obviously in the UK, we weren't told that early on. And actually just those of us who were able to like kind of research and look through Lancet articles and so on, were able to have access to that information. So finally, and that was my final slide on where to get your health advice to. So, any questions? Okay, so is that you, Shayla? So when did it become?
Yeah, that was me.
When did it become visible that BAME was being more effective? I know, I wish I could increase the slides, but let me see if I can do this. Yeah, I'll do it. Is that okay? Sorry, I just don't have it on.
Yeah, that's better, definitely.
So when did it become more visible that BAME is being affected? So I think we always knew that BAME groups, so when I say BAME groups, they're talking about basically non-white people, that they'd be more affected. It's when you obviously look at the UK population, we know that people within BAME communities have lower socioeconomic status. But what's interesting is when I then opened up the newspapers, I think this was maybe about a month in or just before a month in, there was like an image of all the doctors who had died. And also it's because we have some family members, some family friends who was amongst the doctors that had died. But essentially there was a picture of 20 doctors and 19 of them were basically black and brown. And that was the image that really like not freaked me out, but it really like stood out to me. And the reason it stood out to me is because a lot of the times we talk about, okay, BAME groups, they don't have access to health education, they're not able to they have overcrowding in their houses, they're not understanding of the English language as much, they might not understand what doctors are saying to them or the communication. They might have vitamin D deficiency, but I'll talk to you about how dangerous that is, but they might have vitamin D deficiency, and so on, and they obviously have a lower socioeconomic status. The reason that stood out to me was because, okay, doctors, they have access to health education, they understand what's going on with their bodies and their health, and they have probably more access to information about how to deal with coronavirus. Also, we knew that, we know that they're relatively middle class or above, and so that's the image that personally stood out to me. So, once again, I said context is everything. So last week, I decided to do a post on basic institutional racism in the NHS. And the reason I did that was because I felt like for me personally, this was the first time I was able to really talk about institutional racism in the NHS and the things I think behind them. I think sometimes we are so quick to say that people from BAME groups or BAME backgrounds don't understand things or have a low socioeconomic status or have a low educational attainment. And I thought this would be a perfect time to challenge those thoughts. Please answer in the chat box if you wish. So, if you remember, I did this story about a year ago on my Instagram page, and so this is the one that I thought I would share first. So, doctor, why did you say that NHS is institutionally racist? And then I said, because the facts say so. So I decided to share the fact again, but this time share the context, because you can have, and also share the source, because people are always asking, where do you get that from? Why are you saying that? Why are you putting your own cause above other people's? Anyway, so this, as I said before, like the gender pay gap between women of different race groups has little to do with equal pay. Start thinking hard about these questions, and we need to be encouraging our employers also to be doing the same thing. And also we need to start challenging ourselves on an individual basis. Who is getting hired? Who are we hiring? Are we hiring people who only look like us? Are we saying certain characteristics are more desirable than others within our own like racial groups? Which hello? Sorry, I thought I keep hearing someone. Are you thought of as acceptable? Are you thought of as the right fit? Is bullying, harassment something that you deal with more often? And yes. And also, then I thought I would put in I didn't put in the figures because I didn't think it was that important, but actually between consultants who are at that same high grade, that they've also got a widened pay disparity. So I said that they're the same, but they actually widened the hierarchy there. Okay. Let me see. The next one, So this fact, to be honest, all this information has been out for years. America's been doing studies on them for absolutely years, and not just in childbirth or gynecology, but in everything. So the next one I thought I'd bring out is Black women are 5 times more likely to die in childbirth than white women, and that's very well known and very well, but it's not very well understood. We're getting to start to understand it more, and hopefully the next Embrace report will go into those details a little bit more. But for doctors, I think it's important that we start understanding what our individual biases are, because the moment that we perceive someone to be more difficult or to be more hysterical or less educated or opioid seeking, that's when we start to treat them slightly differently. So actually it's all about our internal biases and the way that we interact with certain patients. So I always remember a story when I had a young Black boy who came into the ward. I did about a 6-month job on pediatrics, and that's the career I want to go into. I remember he came into the ward, he was 10 years old, and the reason he was there because he was in foster care, and he told us that he told a teacher at school that one of the foster carers had basically physically abused him. And I remember when we were in handovers, the handover that we do with doctors, so when we hand over from one medical discipline to people who have finished their nights to days, the question I remember someone asked at the time was, "Are you sure that happened? He looks tough, he looks like he can look after himself." And I remember at the time being like, come on guys, we need to start, we can't say that about a child. Like, he's 10 years old, let's just see what goes forward. Because the moment that we start allowing our biases to enter the workplace, that's when we really do our patients a disservice, whether we realize it or not. Yes, so I will go on to the next slide. And absolutely, someone talked about Black people managing a higher pain threshold. There's been lots of studies, and that's well documented and well understood in medicine. Even in America, within the within slavery, there was a lot of American doctors who would operate on Black women, also as a way of educating doctors at the time. There's also a lot of understanding in sickle cell disease, where we don't believe our patients with sickle cell disease that they're in much pain as they are. And we know that all patients with sickle cell disease, once they've presented to hospital after taking paracetamol, codeine, and ibuprofen at home, if they're not able to on that, then they'll need morphine in hospital. But so much of our thoughts in hospital, well, we keep them waiting longer than we do their white counterparts. There's just a lot of information in medicine, and it's very well documented. But let me just go on, because we will stay on that slide forever. As I said, and after Shayla asked in the chat, when is it that BAME groups sort of started to be more affected? Well, we knew from early on, and it was 4 times incidence of BAME groups. And I say the word BAME, even though I don't like it, of COVID, not just infected, but dying of COVID. So yes, so 95% of doctors who died in the first month of lockdown were Black and brown. And the only reason I really picked up this stat, as I said before, is because I wanted to get rid of the over-reliance on socioeconomic factors and get rid of all the stuff that kind of makes it messy. And I think for that, lots of people have keep going back to this misnomer of vitamin D deficiency. And vitamin D deficiency, even though it's been widely recorded in the press, okay, so if you have, just to let you guys know, if you don't already know, I'm sure you do, if you have darker skin, you're more likely to have a vitamin D deficiency, essentially. But the vitamin D deficiency I was talking about in people in darker skin typically tends to be mild. If you're in care homes and don't get out of their houses at all, and will have a more severe form of vitamin D. But also, amongst doctors, lots of Black and brown people just generally will be taking vitamin D throughout the year. And if you're white in this country, you really should be taking vitamin D anyway, even though I know a lot of people don't, through the winter months, and also in lockdown. But anyway, that's just my doctorness coming through, knowing that I have some patients in front of me. So with this question, I just want to move this out of the way so I can actually see my slide. Bear with me. So this is what I want. I think someone in the group asked about, do we know where BAME doctors kind of sit? And the thing is, and they're looking into all that information at the moment, and it's a shame that the COVID report, which came out last week, didn't actually. We can also look at the doctors who are more exposed to patients. So when we look at the doctors who are most exposed to patients, that's your ITU doctors and also your A&E doctors. And actually, we didn't see any deaths amongst A&E doctors or ITU doctors within that first month. And I think since then, there's only been one more death amongst that doctor group. And the reason, obviously, most people will be thinking is, oh, okay, probably because of PPE. But PPE also is really important to consider in the fact that if you're having like adequate PPE and you're being more protected because you're trusted prioritizing user group, that completely disseminates your ability to catch COVID. And I think that's why, that's why ITU and A&E clinicians weren't the ones to suffer it as much. I think the thing also to consider, because we also saw a lot of our Filipino colleagues amongst the nurses dying as well within that COVID period, we have to think about which staff we're always pushing onto the front line, or maybe also which staff are more scared of speaking up to their hospitals and their institutions about getting adequate protection. We have to think about which staff we treat more cautiously and the ones we inherently almost want to protect. I'm not saying, I think there's lots of questions that come out of this slide more than answers, but I think it's really important to consider why 95% of the doctors who died were Black and brown.
Sorry, Emily, to interrupt just for a second. Sometimes your microphone is breaking. I don't know if you can maybe come closer.
No, I can't. I will try and see if I can put my volume louder, and just, do you mind just messaging me in the group if it's still doing? Even if it's just a full stop or something.
Okay.
Ooh. So let's go on to the next slide. So the next slide is Black and brown doctors are reported to the GMC more than twice the rate of white doctors. So the GMC is the General Medical Council, and that's where if there's a professional issue or someone's working against like clinical guidelines, or doing things which should be looked at more closely, those people are reported to the GMC. But the GMC also is quite a formal way of reporting rather than the ways that we report generally within our profession, which typically happens informally. And I'm sure that goes the same with a lot of your guys' profession as well, where actually if something goes amiss, it's about understanding why that thing happened, and then if systematically or if it's very severe, that's when you would think about reporting someone more formally. So the interesting thing about this is that the GMC, so our General Medical Council, they did a report looking in, it was called the Fair to Refer report, and that was finished last year. What they concluded in that report was that if you do not share what they call insider status, I will go into that in a second, if you don't share the characteristics of insider status, then it's more likely for you to be reported to the GMC. So even amongst different groups of Black people and brown people, there was an increased rate of referral in people who had a different accent, people who didn't grow up in the UK, people who went to universities outside of Europe. So the questions I asked, I'm not sure if you can see them on the slide. Your likelihood of being reported to the GMC is intrinsically linked to your distance of having insider status. So questions to ask ourselves are, including, do you wear a hijab? Do you have a non-European accent? Do you wear mainstream Western clothing? Do you adhere to the model minority rules? Maybe speaking in an RP accent, maybe understanding like the jokes and the banter that occurs in the workplace. Did you attend medical school in the UK? So that's for us. Do you understand the everyday Englishisms that are used in daily chat? Are you invited to the pub outings? Do you even feel comfortable in those spaces? I think we need to consider how we interact professionally with people who are less like us. And I'm very aware that I've obviously been brought up in the UK. I have a very RP accent. I understand the cultural differences in the UK. And what's interesting in that report, they understood that people were disproportionately referred to the GMC. So it wasn't that these doctors were behaving in a worse way, it was just that there was no recourse for them other than the formal reporting. And it was the GMC, not me, who said the following. I'll try and find it, hold on. Oh, I changed the word to awkward though. So they also found that evading conversations regarding concerns relating to a doctor's practice in particular, they also found that evading conversations regarding concerns relating to a doctor's practice was a primary factor. So for me, simply put, that what they mean is that their colleagues found it too awkward or too uncomfortable to give them timely, direct and honest feedback. And that's really interesting to report to look into. So that's called the GMC Fair to Refer report. Any other questions, feel free to ask. And then finally, the last thing that I decided to talk about in this is all on Instagram, which is jokes, but anyway, so the last thing I finally decided to speak about was Black NHS staff reporting the highest incidence of bullying and harassment from their colleagues and leaders. And also, I thought I'd also bring up the fact that 92% of board members in NHS trusts are white. And I don't think these two things are directly linked. I think they're just important to consider in the context of the rest of the slides. So when we're thinking about the board members, we're obviously thinking about the people with the decision-making powers, but also thinking about the people who are able to set agendas and recognize what might be going on within their staff groups. And I think it's also important to recognize where that discrepancy may lie. And as I said in that slide, I'm a big believer in cultural change coming from the top. Obviously, the peripheries can make noise and they can tell us what's going on, but really the people who have the ability to make any sort of active change that actually is seen properly and is seen in a less performative way has to come from the top. And if we look at women and medical leadership, we even saw last year or 2 years ago, I think more than half of the royal colleges, so for every specialty we have a royal college, so half of the royal college deans were women. So we can see how so much has changed when it regards women, but also it really has changed in terms of white women rather than women of all ethnicities. So I think intersectionality is very important. There is absolutely no way that maybe a Muslim Asian woman who wears a hijab has the same issues at work that a Black man might have or a Chinese man might have in the workplace. And I think it's important that we start to look at the intersectionalities. And I think what's also really important about intersectionalities is when we're thinking about also white working class men, we know that they don't reach, particularly when it comes to social class, but when we look at white working class men, they're not able to traverse into these more elusive careers or more elusive positions, even when they do come into these industries. And there's a really great book on that actually. It's called The Class Ceiling. So not the glass ceiling, the class ceiling. So have a look at that. But anyway, I think it's really important for us to start looking at intersectionalities, because the moment we look at intersectionalities, that's when we're able to uplift those who are disadvantaged for various reasons, and all the disadvantages are very different. So by pulling up your white working class men, by pulling up your Black women, your brown women, your Asian men, your Asian women, and all the other ethnicities that I haven't mentioned, is really important for diversification of thought. So let me scroll down. So if you remember on that slide, let me just see if I can scroll up. So this is just me. I look at my Instagram analytics. So if you can see on my coronavirus slide, this was the reach it kind of got. And then when I come to this information, even though it's been out for over a year and we've known so much about it for longer, this is how much traction this post got. So for someone who had 2,000 followers literally a week and a half ago, I now have gained something like 7,000 extra followers, and this was the amount of shares and traction it got. So I think it's really important that people do want to know this information, but it's not just data that's important, it's not just stories that's important, but it's about bringing those two things together and giving context. So I'm interested in hearing what you guys have to say about engineering and the things that this might have brought up in your minds, because I think the NHS is a really good example of a group who have been committed to doing research, and though obviously it hasn't quite translated into action, and a lot of the reports do fall short, which I won't go into today, it's really important that they have collected this data so now we can bring context to it. So let's talk engineering. Any questions? Okay, I have my first proper question since my presentation. Go ahead, Mara. Do you want to speak, Mara?
I do, if I can. No, thank you very much. It was an enlightening, and as luck would have it, it's coincided with the report coming out last week, which coincided with all the events that are happening in the world. So you won't get any better time for a social movement than this. But coming back to the NHS, before I suppose leave everybody to talk about engineering, the one thing that was quite interesting for me, and having, you know, and I pretty much can hazard a guess that for a lot of us, this disease has come much closer to home. I've been at the forefront of actually planning a funeral for my mom's brother, you know, on Zoom and all that stuff. So, you know, so I think from NHS, and I speak for, you know, on the wider healthcare sense, the issue that I have with data like this that has been made public, you know, the reports is, it then fails to actually really look at the real issues behind this. So for instance, are there issues, there are certain issues, I suppose, when these started happening around, well, actually it could do with the sort of dynamics, the health dynamics around Black people, you know, more likely to have diabetes, more likely to have hypertension, and more likely generally to work in the healthcare system. However, the other things now that become very apparent is things like a lot of immigrants, for instance, might opt to work for nursing agencies, for example, where they're more likely to work longer hours and without access to without that sort of platform to have a voice. So you work for an agency, you pretty much go in there very blind. You don't know exactly who's ill in there. You literally just turn up for work. You're given the PPE they have on the day. You don't really have a voice because you don't work there. So those sort of dynamics around the people that were affected ultimately led to people not having the platforms or the voices to even voice up when they noted some clear flaws in healthcare. Yeah. This information that Black people are the most impacted by COVID is nothing new. This was actually voiced at the beginning.
Just to pause you on that, I think it's really important for us also as Black people also to not say there's like nothing new there. The only reason I say that is because the information, we need to start also looking at intersectionalities once again, because actually the plight of a Black person who once again doesn't have the protective characteristics that I have, we tend to ignore what they're going through in terms of race, and we kind of just like say it's to do with socioeconomic factors. And I think the issue with medical professionals a lot of the time, and just the institution generally, we're generally quite protective about the way that we treat patients. We swear an oath not to do any harm, and actually people don't understand like how their implicit biases affect like their daily work. So I think it's maybe this past week has been really interesting and important for lots of my colleagues that I've been having all these conversations with, in terms of their understanding of how actually their biases and their race biases does affect the way they treat patients.
I totally agree. I think what I was getting at with It's Nothing New is for the point at which even the impact was well understood that we were really going to be, you know, suffer quite badly from this. But we still had situations where PPE was still found to be inadequate. So at the onset, there were still concerns that there was a certain sort of, there was some kind of, although at the time not supported by statistics, there was still kind of understanding that, well, actually, you know, that there's a quite higher impact or disproportionate effect of this on, you know, people from BAME origin. So even then, we, you know, it took a long time before the system actually, people started reporting better protection. And I say this from even judging from my family, for instance, family, friends, and people within my immediate circle. and looking at the point at which, for instance, my aunt would go to work and today, the difference
Sorry,
is just...
can I ask you if you could come to your point within the next minute? Sorry, I'm just aware we've only got 15 minutes left.
So I think my question was, just coming to that, do you think that there should be more to look at this data to actually really, in order to actually really get through to even things like, like you said, like intersectionality? So there are clearly other things that come into play. It's not just BAME as a topic and all this, but there's other things, intersectionality, looking at what it means for an immigrant and whether that impacts actually BAME immigrants more than, the other sort of BAME people. So is there more, and this also says to talks to engineering, is there more that this data needs to actually uncover in terms of things like intersectionality, actually starting to actually understand the data at a more granular level?
Yeah, I think you're answering your own question there as well, to be honest. And I think we all probably agree when we say yes, it does. And when we look at the report that was released last week, obviously that was disappointing for lots of us for so many reasons. Even if you look at the HSJ, which is the Health Science Journal, they said that the government redacted information, even though the government says that's not what they've done. But that's quite a reputable journal that we read as partners. But I think I forgot what I was going to say. So all I'm going to do, for me personally, right now, is hold like my institutions that I'm part of to account. And also I'm awaiting the government report. So that was the first of 3 reports. The next one's coming at the end of the month, and the next one's coming at the beginning of next month. And obviously the question on every person's lips is, once, okay, it's BAME, but what are the real reasons that are causing BAME to die? Because like socioeconomic groups, when we're doing a medical history, you never like, right, okay, a heart condition and asthma and diabetes, and then low social class, like you never do that. But for BAME, we were doing that. And we were doing that for doctors and saying, okay, doctors, what do you think about us taking off the front line? Like, that doesn't really make sense. What we have to think about are, what are the reasons? What are the real reasons? Thank you for your question.
I have here another question that was quickly put on the group a while ago. I think actually 2 of them, saying people assume that only frontline workers are affected, but some of the BAME NHS staff were quite senior as well. And from the same perspective, saying that you mentioned that on the board is mostly, on the board of the NHS, on the trust is mostly white people, but like when we go to hospitals, we see mostly BAME staff. How is it possible that they only make up 8% of the leadership? Like, what is the gap there?
I'm very interested in data, because data is important, and actually I think that causes like lots of different questions. But if first of all I can say that it is true that 92% of board members are white across all NHS trusts in the UK, and that does not reflect on the numbers, and actually the NHS is the biggest employer of BAME people within the UK. What was I going to say? I think it's also really important to understand how like anecdotal certain pieces of evidence are. And I also understand that looking at just the first 20 doctors, people might say that's anecdotal. But if we think about, okay, when I go to hospital, I see lots of BAME staff. Yes, you may, but actually, once again, it wasn't the A&E doctors and it wasn't the ITU doctors, the frontliners who were dying. So I think it's just important to like look at the data as a whole and see like where the gaps are there, if that kind of makes sense. But obviously I have a lot of questions as well myself.
Okay, thank you. Well, we don't have that much time, so I'll let you go through the rest of your presentation.
So this was also me doing more Googling, because I love a Google. But so I thought, let's talk about engineering. I wonder what sort of things this has brought up for you guys. And if you don't mind just putting in the chat box what sort of questions you have, or the ways in which you think you can start the ways in which you think at your institutions or your career, engineering, as it's your industry, can do better. Please just type in and say what you guys think. So I was trying to see like what your thoughts were, what engineering like considerations were for why people might like leave the career, or why people might feel like they get bullied, or different microaggressions. So I looked at a couple of reports. So this is just one that I thought I would just like capture. I looked through this report. It was talking about people feeling isolated and people feeling that there's sometimes a lack of meritocracy. So not always the best person being picked for the job, but maybe the person who has more like insider status or familiarity with like their colleague or their boss above. Also dealing with that meritocracy despite having Black affinity groups like AFB, for example, feeling stuck and feeling unable to progress, being used as a token. Why does this happen and how do we tackle it? I think these are really important because a lot of the times we focus on why does this happen, but we don't always as a group. And I think that's where it's really important where AFB comes in. How do we tackle it? Because actually it's important to start looking at what other people are doing and how they've tackled it. Yes, so I can see some of you have said similar things that we experience in medicine and as professionals generally. And I love what Ganeet just said, calling out that bad behaviour. Sometimes this isn't always done. That's a massive problem within the NHS. I also shared some stories. I just don't want to go into anecdotes too much on my Instagram and also with my colleagues about the times that I've reported certain people and told them about the things that actually happened as a result of it. And it's been really positive and it's been really helpful. I think it's really important as Black people and people who are non-Black and also of minorities which might be discriminated against mostly more, that we start to advocate for one another and we start to become allies in the workplace. And allyship also looks like an active friendship a lot of the time, where if something's happened to someone and we've seen it, yes, you can speak to the person who's been discriminatory towards them, or we can just simply ask that person how they feel about it, because that's when you start to feel isolated, and that's when you start to feel not heard at your job, or that people are understanding what else is going with you, and that's when you start to internalize certain things. People are trying to join the meeting at this time, imagine. So I thought this was interesting, and this was also something I saw on the gram, just to keep in with my whole gram sentiment. But this was about the influencer pay gap report. So as you know, there are influencers and they get paid for posting stuff on social media. So recently, as of 4 days ago, there was an account that was built up, and the account was called the Influencer Pay Gap. And what they have done on that is asked lots of influencers, Black influencers, brown influencers, Chinese influencers, every single type of ethnicity, just to share and be more transparent in what they're earning and the different and for the same type of work. So that was all shared. That page also has gone quite viral, and it's been really important. And I've seen that also within the publishing industry on how much people are earning, quite literally based on ethnicity and what their access might be. So it's been really interesting just to read all of that. But I think it's important for us to keep asking ourselves, how do we tackle it? Someone said, Nikkei said, I think my personal experience is that BME men face discrimination in our industry too. Wonder if this happens in NHS. Yes, they do. Actually, it's interesting though. When I look at the pay gap report between, so we talked about white women and Black women and that 19p discrepancy. The next biggest discrepancy is between Asian men and Asian women, which I think is very interesting, and it might be telling in a certain way, but actually certain ethnicities have much different discrepancies between their pay, and I think we can see that, and that's also might be to do with the protectiveness of being a man, in terms of being seen as more responsible, and being seen as a leader, someone who can access high positions, and someone who's listened to in certain scenarios. Yeah, the list goes on. I'm sure you guys can think of these things for yourselves. So the next thing I thought I'd bring up, only because my little system happened to mention to me that IBM had taken away or retracted, sorry, you guys will know this more than me, but their facial recognition software. So, by the way, can I just say, when I've written white people don't have ramifications of technology, that's not what I mean here, okay? I wrote this presentation maybe 45 minutes before I got here. So, this was an article, I think it was released in The Guardian a couple of years back, and it's talking about facial recognition and facial recognition for software, essentially. I think what was interesting was that there was a lot of racial bias in which the ways this was used. And I think it's now important for us to think about who's sitting on the tables, who's having these conversations as well, whose opinions are also being like leaned on and asked about and relied upon. And it's also about like diversification of thought and the way in which, if I am putting out a certain piece of like software or working on a certain piece of technology, am I considering the way in which it's going to affect different groups of people? And that might be ethnicity, that might be social classes. I think it's really important to start to consider as part of our roles what like research ethics are, and how we can really be more responsible with our technology. So why does this happen? How do we tackle it was the question again. So I thought I'd bring up some images from fashion, just because they're really visual and they're very obvious. These are some of the biggest brands in the world. You've got Prada, you've got H&M, and then you've got Gucci. And whenever we think about this, some things might be very obvious, like the two images on the side. So obviously, these images have been used to almost like minstrel kind of images. If you don't know the image of black minstrels, just have a Google after this. But these are very images of black people who'd be like jockeying and driving, uneducated, drinking a lot of alcohol, and these are the images. And these things happened just within the past couple of years, and where Gucci decided to have a jumper with the same imagery, and also Prada had these little keychains. And now, why that might not seem crazy to someone who's seen that for the first time, to black communities, that's really painful, that's dangerous. It's purporting images that have been used to hold certain people down. And then obviously that cutest little boy in the middle, I think had there been some black people at the table or even in the studio at the time, that image could have never gone out. And that's really also us understanding that monkeys, apes, gorillas have been used to describe us for absolutely years. It might have been the first kind of thing that we've heard from our classmates when we were younger, or people making amongst us as children or in the media. And I think had there been a black person at that table or someone who has an understanding of race, whether that's a white person or a non-black person, being at the table. So I think it's really important to consider why diversification of thought is important. Why does this happen? How do we tackle it? 2 questions. So finally, yeah, someone also talked about the gang culture campaign that the Tories had put into place. Was it the Tories? Maybe it was actually. But anyway, in a lot of chicken shops in South London, basically, there was a no knife crime campaign on the back of chicken boxes. And you have to really think, okay, so now we think black people eat chicken and they also commit knife crime. Therefore, we now should advertise on chicken boxes. To go from that first thought to the last thought is absolutely crazy. And it's not even that fact that was created, but the fact that it was able to go through a series of funding, also very intelligent people, copywriters, commissioners, and then be presented, and for people to only understand when it came out and caught the furor, lots of people, that was a mistake that they made. So it's important for us to really consider who's at the table. So let's talk BAME. So I think the difficulty when it comes to BAME, and I stole these figures from, what's it called? I think there was a STEM report from last year. So this was, if I remember, sorry, I want to double check, but I'm pretty sure those are the figures for people in engineering. Sorry, this was 2001 to 2011. And I think it's also important to consider when we talk about BAME as a whole group, how we no longer start to see the intersectionalities. So the things that are really affecting people to progress and the things that are affecting people on a daily basis that are causing them not to get certain jobs or to feel comfortable in their workspaces, or to be chosen to be mentored or to have certain contracts or to even be hired in the first place or hired for a more appropriate role. So this is the last way that I thought I could include the Instagram, and that was by having institutional symptoms, internalized symptoms, and interpersonal symptoms. I will be very quick because I see that we've finished now. Sorry, I didn't realize it was 2 minutes past the hour. But it's really important to think about how these things are insidious. And I'll leave that up for you guys to read through yourselves. Thank you very much for having me, guys. Any questions, any comments?
If you want to finish, or you finished the slides,
I have finished.
Just in time.
Go through it a little bit more, but I'll just leave it for people to read if they wish.
Okay, so I know that we've gone a little bit over time, but if anybody has any questions that we can go through really quickly, I think it's an important topic, and all the information that Amelie has presented, it's been quite informative for me in general, but I think for everybody. So please, if you have any questions and you would like to unmute yourself or just
thank you for coming, guys.
Send on the chat, please ask. And yeah. So please just ask on the chat box or unmute yourself. And thank you for the ones who have to leave. I completely understand that. And thank you for joining us today. For the other ones, please do ask questions or any points of discussion that are out there.
Yeah.
Actually, so there are a few questions on the chat itself. So I'll just try to see.
Really? I can't see any.
It probably was from before, yes. Somebody who said, was saying, my private sector company does not collect any data about the ethnic makeup of our staff. Without that data, it seems very hard to make any judgment as to where we are and what progress, if any, we have made. And I think you've highlighted the point that data is so important. I don't know if you have any comments on that.
Yeah, I think it's incredibly, to be honest, it's incredibly important. As we were all saying before, none of us wants to think that we're complicit in making a workplace more like harsh to people based on their skin color or the way we perceive them to be. But once you have that data, that's when you can say, okay, these people are consistently, despite having the same, maybe like the same degrees or the same like starts in life, they are being discriminated towards in like insidious ways. And actually, we need to like start looking into how we better support those staff and how we better look at our own like internalized racial biases, really. So yeah.
Yeah, that's very important because I think everybody has their own internalized racial bias that we're not even aware of.
Yeah. And you always want to see that you're doing the best that you can, and you always want to see that you always want to say that I don't see color, or you know what I mean, or I treat men and women the same. Actually, like you probably just don't. That's even us as women, we don't.
Yeah, no, very, very true. We all, yeah, unfortunately, we're all human beings. Unfortunately, not. Fortunately.
Unfortunately, we're human beings.
Right, I've got
please.
one question. It's
yes,
a very
please ask.
I guess it's a very management type question. I apologize for that. But how would you define success?
Why did you ask that question? Sorry.
No, in terms of we're talking about change. So I'm a very cynical person, and I was, I remember when we had the riots. I think it was 10 years ago after the Duggan shooting.
Yeah.
And I just feel that not much has really moved forward. So my question relating to the current situation is, okay, so we're pushing for change. What does change actually look for us? And how do we actually say we've actually achieved something?
Yeah, I think that's going to be, I think that's my question as well. And I think obviously as someone who's like a non-white person growing up in this country, you've understood that there's been racism ever since like day zero. And for me, I think what really upset me last week was what made me really frustrated with the situation is that there's a lot of people and a lot of my colleagues who only realised that racism was a thing a week ago. And that's a really, really difficult place to like come from. I can say what I think is different. And what I really do think is different is that the atmosphere is different this time. There is absolutely no way in hell if someone asked me to do this talk, like maybe a couple of months ago, that I would have ever felt comfortable giving it to you in the way that I have just presented it to you. My information would have been like more data driven, or it would have been more like anecdotal driven. But what it wouldn't have been is to tell you how it really impacts on people on an individual level and what that looks like in a corporation. And yes, doctors, you're not looking after the patients equally. I could never have said these things. And so I hope that has changed. But also what I think has also changed is that we're holding more people to account. And obviously people have like different ideas and perceptions on what happened in terms of like statutes being brought down, or in terms of like what if ethnic pay gap reporting is like an important factor of success. But I think by demanding this data is going to be really important for all of us, because I think the way that you see success is going to be very different to the way I see success. But I think we can only really start when we have that data. And
I guess you're absolutely right. I mean, when you're able to present that data in a format that management can understand, then it's a much more powerful message. Because it's just tiring to change our behavior to suit other people.
Oh, it's so tiring, mate. This is a therapy session, guys.
Yeah, it is. It's just going to turn into a bitching session. That's about it.
I feel you.
Yeah, I completely agree.
I think Demi raised her hand. Demi?
Yeah.
Sorry, Demi.
No, go ahead. Go ahead, Sheila.
I had a question here from Nikki, which she was asking, do we have the statistics on how many BAME people are asked to work in the COVID-19 wards?
Sorry, who were asked to work in
the COVID-19 wards? Like, do we have any statistics in terms of like how many of the minority ethnic were asked to be put on the front line?
I think to be honest, pretty much everyone was put on the front line. So if we think about it, lots of services were cut, and all the things that could wait were cut, and essentially we were mainly looking after people who had coronavirus. So things have only just changed like in the past couple of weeks, but prior to that, most people are on the front line. I'm not sure if that information is that useful or that relevant. I don't think it's that like statistically significant, if that makes sense. Yeah,
okay. Yeah.
personally. But I think, yeah, because most of us were on the front line.
Okay.
Yeah. Essentially every medical ward was on the front line. Every like ITU department was on the front line. Surgical wards, front line. But I think with hospitals, maybe it'd be more like hospitals could say, okay, who was on the non-COVID wards and who was on the COVID wards, and what do they look like? But
you don't have that data at the moment. I think maybe that's one of the perceptions that we have, that maybe some of the BAME minorities or people.
But I think that takes away. I think that takes away the onus in the medical professional looking after people with BAME, because you're almost going to get data which either supports or doesn't support the notion that people are catching it more. But actually, we need to think about how are people treated with it. Does that make sense?
Yeah, that's definitely something.
I think that's more important, but that's just me.
Yeah, no, I think Nikki totally says what I had in mind, that there was a conspiracy saying that BAME staff were put in COVID wards, but I think it highlighted something there that perhaps I didn't consider, that maybe how are those people then treated as patients, and how does that affect their success or non-success in terms of fighting the disease. Thank you for that. I think that, yeah.
Can I say lastly, I focus on Black and white people purely because of the events of last week. But obviously, I think what I care about even more is really intersectionalities and what that means for people of every single different race.
Yeah.
We know that like white men and like South Asian men are looked at as like leaders more often in a way that other groups of men aren't. And then we also know that like South Asian women aren't looked upon as leaders compared to maybe like Black women sometimes, for example. So I think it's really important to understand what those like intricacies in like
intersectionality, as you mentioned. Okay, I don't want to hold us off for much longer, so I'll let Demi ask the question because I stopped her, and then after that we'll wrap up. And thank you everybody for bearing with us, even though we're running away with time. So Demi, please ask away.
Thank you. Thanks, Winnie, for your presentation. And this is tying into what sorry if I pronounce this wrongly, please correct me, Hingwai was saying. I think the change now is technology, and having data and also technology that aids the cause, to showcase like how people are saying that they're still shocked, or they still they don't believe that this is happening. And it's kind of showing and encouraging people. Like your presentation was it was easy to understand because you had facts behind it. So it's not because it's such an emotional subject. This time we've got the facts, we've got the videos, we've got the pictures to prove these things. So I feel like change is coming in that way. Technology is working in our favor now. And my question is similar to him. It's like change, but at what cost? Because I see, I do want a better, to be treated better in society, but I also look at the cause of people that are, I don't know how to say, innocent or on the right side of history. And I just see like, if we, is it white fragility? I don't know the words to put this together, but if we're all speaking up at this point in time, there's a lot of, I don't know if it's fear or people don't know how to have this conversation. And I'm just thinking, like, in your experience, in your industry, is there any suggestions or having to make sure it's not a fight, it's a movement? So I don't know if there's any advice you've got for people that are going back into these spaces and want to have this conversation, but you can already see the walls are up before the moment you enter the room, or the moment you even address the topic.
This is why I keep coming to the back to, it has to be like a culture shift from like from seniority as well, because there has to be a way in which seniority is able to like point out certain resources, but point out the data that supports the reason why people should be interested in these resources anyway. But I can say, obviously, they're probably like one of the few professions who have actually been able to see each other like all the time during this like COVID period. And I think last week is the first time I've had conversations with my colleagues about the ways we treat patients of like different colors. Like that was literally the first time I've ever had these conversations in my entire life. So I am encouraged by I am encouraged by these conversations, but we just need to figure out a way of like getting them to be there continuously. And I think a really great way of getting them to be there continuously is asking our professions to release what their like ethnic pay gap data, or who sits on like the board, or who sits on the boards, what do they look like, who the recent hires were, what is HR's policy on hiring, do they have like all white panels or all male panels, do they undergo like racial bias training? Like there needs to be stuff that we start to demand from like higher up, and that's when we'll see these things infiltrate. But I think also above all, like on an individual level, everyone needs to be like in that conversation of what is it personally that I like, what is my personal work that I need to do? Because I understand like British history because I've always been interested in like the history of like colonization, but that's obviously because I was like born in Nigeria, and that's the world, that's like the world that I've like always lived in. But and also like on a patient level, I've also seen all that data and history and like journals about the way that people are treated differently in healthcare, and that's been something that I've always been aware of. So I think once people are being given awareness of like the context, but also that data, as we keep going back to, that's when things will change. But I think management, we have to like push our management structures to be doing like the important work. And also there needs to be a way of like reporting these incidences of bias. Like someone needs to be getting that data, whether they do anything about it or not at the time, but someone needs to be like aware of it, and management does.
I completely agree with you. And I think
I'm not answering Hingwai's question.
Okay. I agree with everything that you said, and I think some very good points have been raised throughout the discussion. I felt like it was very interesting and very raising the awareness for all of us. I think the points on intersectionality that you had, the points of not being afraid of discussing the topic anymore, the points
and
of
demand meetings with your work. You have to demand meetings, and you have to expect a statement. Like it's not okay for for industries not to be making statements now.
I
Not
completely
brands,
agree.
because I don't care about brands, but your companies in which to employ you, they need to really make you aware that they will look after you as well.
Make you aware that they support you, and this needs to come from the top down, not from the bottom up.
Absolutely.
And
Absolutely.
I think
but what bottom up can do is like to show your list of demands. There's no better time.
Completely agree. Well, thank you so much for taking the time today to join us and to do this wonderful presentation. I do hope everybody really enjoyed and really was part. I can see there was quite a lot of participation on the group, so thank you very much for that. We have quite a few events coming up. So this Saturday we have a STEM, Careers in STEM, Pathway to Success. So this is between 12:30 and 1:30. This is mainly for young students or people who are looking into what do they want to be. So if you have sisters, brothers, children, cousins, please do share with them, because it'll be quite interesting. And next week we have another event that does again look at diversity, and it's called Let's Talk About Leadership, and focus in a way into the minorities and the lack thereof in leadership and how we can get there. So yeah, please check our website regularly to find out about future events. We have them quite regularly, so yeah, please check it. If you have any further questions, please send an email to info@afb.org.uk. Our website is afb.org.uk, so you can find a list of events there. Find us on social media on the usual places: Twitter, Instagram, LinkedIn, Facebook. We're all of them. And please don't forget to leave us a comment, subscribe, join us, or follow us, as I said, on social media. We also have a YouTube channel, so this has been recorded today. So after we cut a few ums and
I was like, oh, careful. I'm at my profession. Like I'm confident to speak, but not all.
We'll make sure that you're happy with it before we post anything. And we'll be sending very important feedback forms back. So please, these are very important for us to monitor our progress and what we need to improve or not. So please, if you can take some time and complete and return them to us, we really appreciate it. And thank you, Amelie, again for taking the time to give us this very insightful discussion. And to everybody who joined us today. Have a great afternoon.
Bye.
Thank you. Bye. Bye.